Today's healthcare delivery remains burdened by complexity, inefficiency, and difficulties in making technology truly work for everyone. Allscripts is changing that. We're creating healthcare that's smarter, more connected, and alive with possibilities. Our solutions are built for greater connectivity, using cutting-edge software and technology, open architecture for scalability, and delivering the most innovative and responsive EHR, financial management, and patient engagement tools. Our services provide the critical support clients need to optimize performance and productivity, leading to better patient care. We empower our clients to deliver even greater value in everything they do. Our insights are more focused and actionable, guiding investments in key growth areas and revealing opportunities to diversify services and solutions. Our client stories are more impactful and relevant, illuminating best practices and industry trends that are making the greatest real-world differences. Allscripts is helping realize the amazing promise of medicine for people everywhere, creating a healthier world alive with possibilities.
Good morning, everyone, and thank you for attending and being part of this virtual summit. It's our second of the year, and we are being broadcast through the Middle East and through China as well. And this morning, our keynote is someone who I've been working towards getting on board for a number of years, and I'm delighted to introduce Mr. Alan Fowles. He is president of Allscripts International out of the United Kingdom. Allscripts is a global leader in health IT with world-class solutions, including clinical information systems, population health management, interoperability platforms, analytics, and precision medicine capabilities that enable organizations worldwide to change what's possible in healthcare. Allscripts is the second largest public health IT company with clients in over 17 countries, supported by nearly 9,000 associates. It's been awarded 46 patents in the past 3 years, and Allscripts is proud to be one of the most innovative HIT companies on the planet. With more than 30 years of experience in global healthcare, Alan has focused on business growth, market entry, and developing leaders for healthcare technology companies. He has held leadership positions in several listed companies prior to joining Allscripts in December 2016. Originally a clinician, he held a number of senior clinical and hospital management positions within the UK and Scandinavia. He holds an executive MBA from Ashridge Management College, affiliated to the City University of London. With that, thank you, Alan, very much. I'd like to turn it over to you. And the title, as you see, is The West, Middle East, and Far East Collaboration, the New Healthcare Triumvirate for Stability and Scale. Could not be more appropriate and timely. Thank you, Alan.
Thank you. Thank you very much, Ransel. And well, good day, everyone. And thank you, Sam and Ransel and Dr. Abu Alpha for inviting me to speak today and to join you. It's something we've been very much looking forward to. So, the world has changed. We're at a point where we can choose to accept what's happened and move on, or not. The choice is ours. To accept means to work together and to do things differently, to strive towards something better. Let us start by reminding ourselves how the world changed in the last 12 months. COVID-19, so far, the number of confirmed cases globally is over 56 million, with almost 1.36 million deaths. In the US alone, there have been over 10.3 million cases and 240,000 deaths. We're currently in the process of trying to find a new stability, and any solution must be at scale, in other words, global. Using the words from our hosts, if I may, it's very much about navigating the healthcare diplomacy and looking towards collaboration and innovation in all parts of the globe, in the West, Middle East, and the Far East. And we have to look towards not just digitally mature countries, but recognize that innovation can also come from those regions or organizations who are currently less digitally mature. But To that point, they may end up leapfrogging and overtaking those of us who are perceived to be more digitally mature currently. I recall whilst working in South Africa in the 90s, where I saw an extensive fibre network across the country, providing fast and reliable communication, just as we expect our networks to do right now. Back then, it was managed by and only available for the military. As mobile telephone technology became more commonplace in the region, we saw innovation spring up in various sectors, including the financial sector, where they started to use this new tech and very quickly adapted it in such a way that it not only worked as well as the fibre network, but excelled and provided the opportunity to present new and superior service out of necessity as a device to support financial transactions, for example. This necessity and drive may not be something that we typically feel in the more digitally developed world. Regardless of this, we must embrace solutions and innovations from wherever they originate. Now, let us start from where we are right now. Consider our current hurdles and then look at how we can meet those challenges and come together to overcome and excel. COVID-19 is an illness. The definition of an illness is an unhealthy condition that affects the mind or body. In this case, it affects both. Unhealthy, health, healthcare. It's the concept, the idea, the model of healthcare that will help us navigate through these times. Underpinning decisions in healthcare is information, data, in other words. Aside from the human tragedy, COVID-19 is a story of data. And data originates from solutions such as electronic medical records or EMRs and shared by health information exchanges or HIEs. Of equal importance is the need for this data to provide information in order to inform those that have to make difficult decisions. Therefore, that data must be actionable. It has to support decisions such as, should I admit this patient? Do they need an ITU or HDU bed at a time when these resources may be sparse? All the way to, should we close a town, a city, or even stop travel from another country? These are very real decisions currently being taken around the globe right now on the basis of available data. Let's not get ahead of ourselves. Before we look towards the future and how we can all support each other, let's look at the challenges we encountered at the start of the pandemic. In the West, Middle East and Far East to move forwards together and create a more stable and scalable healthcare society. It's interesting to observe not just the differences in the challenges encountered across the world by healthcare organisations, but also the similarities as well. The following high-level examples have come from the experience of some of our customers, our partners, covering acute, ambulatory, community, as well as our regional healthcare organisations. It's also important to note that these organisations are from all over the globe, including the US, Canada, Middle East, UK, Southeast Asia, and Australia, to name but a few. Last year, the newsfeed started to talk about a relatively little-known virus that seemed to be localized in a small province in China. Whilst it did manage to make the news, for many of us, it was something that was happening a long way away. In February, that seemed to change. We opened our eyes, and this happened roughly at the same time all over the world. Over a period of 3 or 4 weeks, we went from no response to what was described by one of our customers, Chief Clinical Information Officer and practicing clinician, as a full-out war. It was and still is a global major incident. What we thought of as normal in most aspects of our lives changed. You can almost go as far as saying that it rocked our view of day-to-day life, our stability. We had to respond. Let's look at some of the challenges encountered by our organisations finding themselves on the front line. First of all, communication. All aspects of communications were affected. This included information being sent to key organisations to let them know what was happening, as well as communication within the organisation's own structure, from the senior leadership down to those on the front line, and from clinicians back to their organisation's management. Face-to-face meetings had to stop, which meant those board meetings, when decisions would normally be taken, could not take place initially. The same applied to departmental meetings and so on. This led understandably to a lack of coordination and insecurity, which was widely reported, and in some cases still is. Then we have the operational challenges that face many governments and in turn organisations. This included the supply of equipment, whether it be medical, such as personal protective equipment or PPE, and ventilators, or non-medical but equally important equipment, such as technical hardware, PCs, laptops. The latter was crucial in allowing organisations to support staff being asked overnight to work from home. This in particular was something that was previously never really considered to be a viable option for those in healthcare. The option of working from home has been available for some time. However, it was the scale of the ask that became the challenge. Other operational challenges included the need to dramatically increase the number of intensive care beds, as well as the reorganising of the flow of patients, both within the hospital walls and outside, to separate patients with potential viral signs and those without. In the acute setting, something as simple as moving a patient from an emergency department to a ward became a logistical nightmare. Whereas in the community, waiting rooms became a focus of attention. So a whole rethinking of where to put waiting patients became a headache for ambulatory care. Away from the direct acute setting, a common challenge faced across the world was how to increase bed capacity generally, by utilising resources outside of the conventional hospitals, such as car parks in Singapore by Sing Health, tents in Central Park, and Nightingale hospitals in the UK. As COVID-19 cases started to rise and staff started to become sick, there was the additional complexity of running the various organisations with reduced skilled resources. Healthcare had to continue, and we still had to find a way of supporting non-COVID-19 patients, those with cancer, minor conditions, chronic conditions, and so on. This was an ongoing challenge. It was met in part by telehealth, a solution that has brought its own complexities when rolled out at scale. This was yet another example of something that's been around for many years, underused in most of our clinical lives, and now becoming a regular feature. Within my own organisation, we've seen a 9,000% increase in telehealth usage across our client base. I'm using the term challenges here. However, some may describe them better as huge logistic headaches or nightmares. Infrastructure was and still is another huge challenge. Organisations had to ensure that infrastructure such as Wi-Fi and VPN access was able to cope with staff remote working, as well as an increase in the reliance of Wi-Fi to connect patients in hospitals with their loved ones at home. In a lot of cases, this was the only way to see each other, and for some, tragically, the last time they saw each other. Going back to one of our customers, Sing Health, in some aspects, they were better prepared than most to deal with the pandemic based upon their extensive experience with SARS. However, they did face a challenge in bringing hardwired networking outside of their hospital, initially introduced into their car park to support a Nightingale-style hospital setup, but then expanding their telemedicine capability to support patients beyond that within the community. There were additional challenges experienced by staff having not only to work wearing PPE with all the discomfort that comes with the masks and gowns and so on, but also being redeployed into areas where they were not used to working, including the community. Talking with our EMEA Chief Clinical Information Officer, Dr. Konstantin Jaberin, who also continues to practice in the ED himself, I'm aware of how unsettling unfamiliar surroundings can be to some clinical staff, particularly during periods of stress. Standardization was another challenge. Within a single organization, a standard process or guideline would have helped settle some of the uncertainty felt by those working on the front line. Standardization and guidance across the country or countries would have added additional stability and unity. What we found instead was an initial lack of standardization, which in turn contributed to the perceived instability. This in turn added to the uncertainty that was felt by the frontline teams facing this illness. Examples of this included the guidelines around PPE usage sent to hospitals and other healthcare settings. For the benefit of diplomacy, I'll refer to the UK, where we saw a shifting of PPE guidance as the pandemic progressed and escalated. It changed as PPE became increasingly difficult to source, such as what level of protection to use and when. There was also uncertainty around what treatment to use in order to provide the best care for patients, and so on. It was felt that guidance seemed to change based on supply and demand. In other words, based on what was available. And at times, globally, we also saw advice of the World Health Organization being either contradicted or ignored, again fueling uncertainty. One of the biggest challenges at the start of the pandemic, and one that continues to be an issue, is the lack of accurate and timely data. At a time of crisis, more than ever, we need big data. It is this information that we base strategic decisions upon. A lack of data, and equally important, the wrong data, can have a significant impact on key resources. It will also affect the confidence felt by organisations and the public. A lack of confidence and poor decision-making will filter down to the front line. Examples of recent poor data include the double counting of COVID-19 tests in the UK in May to August of this year. The tests were initially counted as they were sent out to hospitals and care centres. They were then counted again as they were sent back and processed by an independent lab. This led to an over-reporting of the number of positive tests during that period. Focusing again on the UK, there was a data error in September-October, leading to nearly 16,000 positive COVID-19 cases being misreported. Although the positive tests were shared with the individuals affected, the associated close contacts were not informed. We can see in these two examples how the wrong data was used, leading to an exaggeration of numbers on the one hand, with all the associated negative press, such as numbers going up faster than expected, to an underreporting, leading to potentially an increase in cases due to the close contacts being unaware that they could be a risk to themselves and others. Both would have had a negative impact on morale to both the general population as well as those working on the front line, clinicians and non-clinicians alike. Was it all bad? Adversity can often bring out the best in us. There were some good things that came out of the emergence of the pandemic, always, of course, remembering the suffering that many have gone through. People adapted, and as individuals settled, so did the organisations they work for. As a result, we all started to see better communication, and as the communication within organisations increased, we saw an exponential acceptance and subsequent use of teleconferencing solutions. This was fueled by the need to continue to support interactions with patients where possible in clinics, in primary, ambulatory care, and other non-intensive clinical settings. Prior to the pandemic, 95% of patients in the UK in the primary care setting were seen in person, in the clinic room. In the middle of the pandemic, this had changed to 99% of patient appointments being done virtually. In the US, the AMA noted that physicians and other health professionals are seeing 50 to 175 times the number of patients via telehealth compared to face-to-face before the pandemic, according to a report by McKinsey's. The report also adds that virtual visits could now potentially account for $250 billion, or about 20% of what Medicare, Medicaid, and other commercial insurers spend on outpatients, office, and home health. We've seen a huge shift to telehealth, and although I suspect there'll be some form of rebalance in the near future, telehealth medicine, I believe, is now very much here to stay as part of mainstream medical practice. This view is also supported by the increased global investment seen in Q3 in telehealth solutions. According to CB Insights, global deals were in excess of $2.8 billion. It's also important to note that reimbursement was the main barrier to remote consultations in some countries, and governments also have to address this as part of the clinical solution. Healthcare started to evolve. Another way of putting it, healthcare globally started to come together to offer a more stable offering. And this was seen at an unprecedented rate, especially during the first few months of the pandemic. For example, implementations continued, and in some cases, such as the Dudley Group NHS Foundation Trust and Gloucestershire Hospitals Foundation Trust in the UK, the implementation of solutions was in fact accelerated to great clinical benefit. Dudley had planned to deploy a population health solution, DB Motion, fully at some point in the summer after a period of internal testing and proof of concept with the general practitioners in the area. However, as a direct result of the pandemic, the deployment, which was planned to roll out over a 3 to 6 month period, was instead accelerated to 10 weeks with great success. The solution DB Motion allowed a two-way flow of information between the hospital and the GPs in the community, critical at a time when information was needed quickly and efficiently. Gloucester were due to roll out the observations when COVID-19 became a reality in the UK. Instead of putting the project on hold, it was rolled out again at accelerated speed with a revised methodology incorporating remote project work. They recently won a national award recognising that fantastic feat. These are just some of the examples of where organisations accelerated projects to provide stability by ensuring the work not only continued but completed at an accelerated rate. And even this week in the UK, one of the UK's largest NHS trusts, East Kent, has gone live with a new ED solution whilst dealing with increased demands of the second wave of the virus. These were brave decisions, but the added pressure drove innovative ways to deliver solutions more quickly, having understood the impact that they would make on patient throughput and management, as well as the actionable data it would bring to support their decisions. It's not really a new normal, but a new expectation that's been established. Focusing on the acute sector, EMR solutions such as Sunrise and others supported and continue to support healthcare at a time of crisis. They should do this by delivering a solution built by human-centric designs, which needs to be driven by clinicians, not technologists. They have to be intuitive, easy to use and to support, not hinder the clinical workflow. They should also provide cognitive workflows, incorporating clinical decision support based on accepted standardization and guidelines, such as, for example, the acute kidney injury pathways, a condition that's very common in sick patients, including those with COVID. It's crucial for these patients to be assessed quickly, identified and managed appropriately. We, however, should go beyond what's being offered by many EMRs. We should be utilising knowledge bases to underpin the clinical decision support and enable safer, smarter care. In addition, the solutions must be designed to work on any device, desktop, laptop, tablet or mobile. They should provide the appropriate functionality based on the device they're being used on. In SingHealth, as mentioned already, their challenge was not in setting up the processes within the acute setting of the hospital. It was in fact supporting the work outside the hospital, in the community, in the remote clinics and in the car park. For solutions to support this kind of mobility, they need to be flexible. And this kind of flexibility can be optimized in a cloud-based service. This would allow not only the flexibility in the form of mobile working, but also scalability. Cloud-based solutions on the whole can help meet multiple aspects of the challenges that were faced by clinical and non-clinical staff alike. One of the reasons we as a company are pushing forwards with our cloud-based solutions. There are others doing the same. Benefits in particular right now include the support of mobile working, both in the full sense of mobile supporting patients in the community as well as remote working, allowing clinical and non-clinical staff to work from home where possible. In addition, we can support our organisations by taking away from them the burden of having to manage their servers, maintenance, security and cybersecurity. Of course, moving to the cloud also supports patients via the Internet of Things in healthcare, by opening up possibilities to support patients outside of a healthcare facility. In doing so, organisations would be in a position to manage their beds and to allow earlier discharge of patients, allowing them to recover at home. cloud also has the added benefit of being able to support all of the above at scale. We've built up a picture of what a modern healthcare solution should look like, a sophisticated HIE and EMR that's supported by a knowledge base and clinical decision support available on any appropriate device, specific to the venue of care. Now for the overall solution to fully support our clinical staff, it must also be an integrated offering. The solution itself must be open, support interoperability in patient context, for example, with tab functionality, but it needs to be more than that. Our solutions need to also share data. They need to offer the right information to the clinician when they need it. This is what was offered to Dudley when they accelerated the rollout of their DB Motion population health solution. The ability to share simple information, such as patient drug histories, past discharge summaries, notes, pathology, and imaging. In Dudley, it was rolled out during the first wave. It's now in place to support this current second wave. Another example of an integrated solution is the offering to Al Farden Medical in Qatar in partnership with Northwest Medicine out of Chicago. A combined integrated implementation offering a fully integrated electronic health record that connects all aspects of care, including ambulatory, surgical, radiology, and lab services. Another project which went live during the pandemic using remote methodologies. I've shared with you the challenge around data and what can happen if the data is wrong. Going forward, it's crucial that we offer solutions around data, in particular big data. As mentioned, it's this data on which decisions are being based upon. Whether you're a nurse trying to decide whether to activate an alert or a government assessing whether a policy of shutting down parts of the country is working, you need that data. Therefore, data must be captured in real time where possible. It must be accessible by those who need it. It must drive processes and solutions, in particular within clinical systems via clinical decision support. It must also be capable of providing benefit at scale, whether that be the data itself or the outcome. And it should be dynamic, be able to scale up regardless of patient populations and be able to meet and support unexpected challenges. And so what for the future? Let us look at what those on the front line want and need, and in some cases are receiving, and then move to where the investment is pointing towards. Clinicians are looking for knowledge sharing. They're looking to be able to have as much useful targeted information as possible to allow them to make decisions. This is simple, actionable patient data that's easily accessible from anywhere in order to support patient care. They also want knowledge sharing to go beyond their own four walls. They need to be able to work in an open global healthcare system where best practice is accessible for all and where research can be enhanced and developed with global efforts. Regarding standardization and guidance from appropriate learned bodies, again, we'll have to look beyond our borders towards organizations who are in a position to guide, who are in a position to bring together good practice and standardize. Bodies such as the WHO, UNICEF, Médecins Sans Frontières, the Red Cross, Red Crescent, all have parts to play as examples. This would result in measured, informed decisions and avoid scaremongering, panic, and poor choices. We must focus on healthcare solutions that can support the current situation, dynamic at scale and remote healthcare. This includes the evolution of telehealth solutions, not as isolated software, but provide seamless interoperability from the point of view of the clinician. We must offer them solutions that work, providing immediate benefit. We must also continue to innovate and invest for the future. Regarding innovation, we should leverage experience from other sectors, such as gaming, where human-centric design may be further ahead than in healthcare. And regarding safety, we can look at and continue to look towards the aeronautical industry, where design and safety go hand in hand. Think of black box thinking examples. And where's the investment going? When looking at healthcare as a global industry, CB Insights indicate that there's been record investment this year, with a new quartile record in Q3. The world is investing in healthcare In North America alone, there was a 20% uptick in investment. This was also seen in the Asian market. Of particular interest, perhaps not surprisingly, was the investment in artificial intelligence, over $2 billion in Q3. After all, this is the future of medicine, the next step in clinical decision support. The other not unexpected areas of significant investment were in telehealth and of course R&D in drug tech, where this week we've seen the first encouraging news on a vaccine. Telehealth saw a global investment of $2.8 billion, with nearly $1.5 billion in R&D for drug technology. So let's bring it back to where it all began, with change. We're on a journey which encompasses change. Sometimes the change is more rapid than we feel comfortable, but there is always change. And successful change is dependent on all of us coming together and supporting each other. Clinicians, vendors, research groups, governments, and more. In the US, a published research article several years ago found that once best practice had been identified, it took, on average, 18 years for 50% of the clinical population to adopt it. Similar patterns are to be found in many regions. This is clearly unacceptable. The technology is evolving quickly. We've seen that we can act quickly and effectively when stressed by a pandemic. Today, we've considered challenges accelerated by COVID, but these challenges were there prior to COVID. We've just reacted with more focus and alignment globally. We have a great opportunity to advance our healthcare systems across the world. With that opportunity comes responsibility. A responsibility to provide the best healthcare services possible, and a responsibility that we should all take on together. Thank you.